Greetings everybody here in the audience, and it is a real honour to be able to present to you at this Sigma conference again in 2020 it is now. Great shame I can't be here. It really is a personal regret of mine not being able to make it, but what do we all think of this venue, ladies and gentlemen? Truly spectacular. You can always trust the CI journalists to come up with some flash terminology. Now, my job today is to talk to you about how you're going to adapt your new practice to deliver on a new contract. We all know we've started to move from the delivery to services. That's going to mean an awful lot of changes in the community pharmacy setting. Some of these might be physical, some of these might be mindset changes, some of them will have to be the way that we practice our profession. And in particular, I want to talk to you today about a new supervision regime. Now, many of you will be very familiar with the PDA's role in the whole supervision debate to date. So I'm going to give you a little bit of history on this. The proposals for remote supervision started in 2006, and it was one of those bizarre arrangements where the government had a survey and asked pharmacists whether they wanted supervision to change. And of course the vast majority of us said yes, because it's not fit for modern practice. But what they gave us was this plan to operate a pharmacy in the absence of a pharmacist. Well, that was never what we voted for. And it's a little bit like going to scout camp when somebody says, can you ride a bike? Hands up all those boys who can. You put your hand up and they say, right, go and dig a latrine. It was that kind of deal that we as the profession got at the time from the government. The idea was that the pharmacy would be allowed to operate in the absence of a pharmacist. Of course, we were mortified. We at the PDA certainly were, because by 2006 we were already looking after the interests of the pharmacists at the very coalface. So they split the transaction into two halves. By 2009 they were going to lay the RP regulations. This was going to allow a 2-hour absence for the pharmacist, but the responsible pharmacist in their absence would have to be responsible for the safe and effective operation of the pharmacy during their absence. The second stage, which was going to be a longer period of absence, was via remote supervision. That was going to be the next step. Well, of course, we immediately went into lobby and campaign mode, and we were very, very active in Parliament. And although there were many, many MPs and Lords that got involved, here were some of the most interesting remarks, key remarks that were made. Lord Howe made this back in 2006. One of the profession's main worries, I mention in particular the PDA, is the extent to which it is reasonable to allow the pharmacist to be absent from the pharmacy, whilst ensuring that patient safety is not compromised. And Lord Howe said, the watchword here, as the Minister himself emphasised, must always be patient safety. Patient safety, that's an important key component of supervision. Baroness Murphy, she said in 2006, it seems to me, and this has been raised by PDA, that the provisions, if not properly implemented, may have unintended consequences of lessening the public's access to a pharmacist. At a time when medicines are becoming much more complex and more personalised, it seems to me to be potentially harmful to remove the personal relationship between pharmacists and their customers. This has been central to both quality of service and patient safety. So, unintended consequences, another byword of our ongoing campaign. And finally, Baroness Barker, I think she pretty much nailed it. The days on which pharmacists really earn their money are those when they are working in the back and happen to hear something going on in the front. They wander out to join the conversation. It's a proximity issue, whereupon they pick up details such as adverse drug reactions on repeats and are even able to detect certain conditions by a person's odour or pallor. Those details could not be picked up by remote means described by the Minister. The Minister, of course, was talking about a camera somewhere in the pharmacy that would be able to observe the transactions going on in front of the shop. They cannot be picked up by remote means described by the Minister, but they often lead to important medical interpretations. So the proactive and reactive availability of the pharmacist has to be a key component of any future supervision programme. Now, the government responded. We were throwing in stones at some of these arguments. At the time, 2006, if you remember, the RPSGB was a regulator. It was ambivalent about supervision because it regulated the profession, it regulated pharmacies. We, in 2006, were the only organisation that really campaigned against this. Fortunately, many of the organisations have now realised that this is not a good thing. So Lord Warner, in Parliament in 2006, gave the following assurances: that RPs should have some experience and a few years of registration before they become a responsible pharmacist. Responsible pharmacists would have their name annotated on the register, somewhat similar to a qualification. Pharmacists would have training before the regulations were introduced. These are all assurances we were given by government. Of course, none, not a single one of those things happened. But the most important thing, and this is the thing that really does worry us, when we asked the government what would happen to patients, who could they turn to for advice in the absence of a pharmacist, Lord Warner indicated that patients would always have access to a suitably trained healthcare professional in the pharmacist's absence, such as a pharmacist technician. Now remember, this was 2006. This was before a register of pharmacy technicians had been created. But that one sentence, and that one sentence alone, gave us huge concerns about the long-term strategy of the government. But it was clear that they sought to put the pharmacy technician in the place of a pharmacist in a community pharmacy setting, and what was going to be shortly on the horizon was clearly some kind of a registration process that was going to create some sort of a quasi-profession overnight to fit in with the government's plan. That one sentence alone created a huge amount of tension between pharmacists and pharmacy technicians, and it created a huge amount of resentment between pharmacists and the government over its future intentions of what was going to happen in community pharmacy. What else were we told from time to time by senior civil servants? The 2-hour absence would be used to develop the professional services, and the reasons for the absence would be recorded in the RP register. Well, of course, that didn't happen. Only the pharmacist could decide upon how the 2-hour absence would be used, for professional purposes, of course. Well, that was before some of the very large multiples invented the advanced declaration template. This is the document that's signed by pharmacists when they're going home in the evening, which allows the employer to use their 2 hours absence in the morning from 7 AM before they arrive at work at 9 AM, having used then their 2-hour responsibility to allow batch prescriptions to be dispensed in the pharmacy in their absence. That wasn't intended, was it? But that's how this 2-hour absence is being used. They told us that protocolisation would keep patients safe. Well, those of us who are familiar with what happens in a pharmacy know that life is the thing that happens to you while you're busy making other plans, and protocolisation will not keep patients safe because it can never anticipate what's going to happen at the coalface. They also told us pharmacists would need to be contactable and able to return promptly if they were absent from the pharmacy. Well, if that makes sense, then frankly I am a banana. Can you imagine leaning over an old lady in some consultation room away from the pharmacy? You're just about to administer some new service or piece of advice, and suddenly, diddle-da-diddle-da-diddle-da-da-da, these were the ideas that were coming out of the Department of Health. None of this made any sense, none of it was safe for patients, and none of it was a plan that we could ever support at the PDA. So our campaign gathered in intensity and momentum, and 3 fundamental principles existed here. Our belief is that a pharmacy without a pharmacist present is never going to be as safe as when a pharmacist is present. The second one is that it is a core expectation of the public for a pharmacist to always be available for consultation in the community pharmacy. That is an incredibly important component of what a community pharmacy has to offer. Now, the third part of our campaign is these ideas about remote supervision, about operating a pharmacy in the absence of a pharmacist, fails strategically to make the best use of a community pharmacist and the community pharmacy. And because of that, it is inevitable it will lead to professional disinvestment in community pharmacy and ultimately to financial disinvestment in a community pharmacy. Back in 2006, people shook their heads. Some people thought this was going to be the opportunity to increase margins because their costs were going to go down. Now, we all now recognise the dangers of potentially a professional and financial disinvestment in community pharmacy. The government was so bogged down between the years of 2006 and 2012. Every time they were about to come up with something, we were able to harass and harangue them with the patient safety arguments. They finally passed it to this outfit called the Rebalancing Medicines Legislation Pharmacy Regulation Programme Board in 2012. Individuals hand-picked by the chief pharmacist to sit on that committee. No surprise perhaps, we as an organisation were not invited to the party and we are not members of that programme board. They had a number of jobs to do, but in relation to supervision they were told fix the supervision issue and we all know what that meant, and make better use of pharmacy technicians. Nobody could have expected this. 5 years later, this has been rumbling along, and in 2017, we're all familiar with it, a shocking revelation. In what I guess we can only describe as a quasi-whistleblowing type situation, some member of that rebalancing board leaked a paper of the supervision working group, had some very, very senior players on that working group. And you can only imagine the force and the influence with which this supervision working group document would have had on that rebalancing committee, had it not been leaked. And this document said that the sale and supply of medicines in a community pharmacy should be supervised by a pharmacy technician in the absence of a pharmacist. This is even worse than remote supervision, because it completely seeks to disintermediate the pharmacist from supervision in a community pharmacy. So shocking were these revelations. So far did those reverberations go round all of the pharmacy media and even nationally, that the health minister was forced to distance himself from this policy in Parliament. Yet again, the rebalancing committee had to take a really big hit on the chin. That was in 2017. Since then, very little or no progress has been made, but patently, with the emergence of the new community pharmacy contractual framework last year, where there is now a very, very welcome move towards provision of services in the community pharmacy, that work is now being looked at again by the Department of Health. And it is our belief that it is time for the profession to come up with viable ideas on supervision and be the architects of our own future rather than to be victims of somebody else's plan. And that's really why I'm here today, to put forward the ideas that we have got at the PDA. So what are these ideas? Our ideas is based on this definition of supervision, which is based on all of the comments that we got from members of the public in focus groups, other healthcare professionals, parliamentarians and lords in Parliament. Supervision can only occur, and this is relating to community pharmacy, when a pharmacist is in the position to intervene both proactively and reactively in patient-facing situations with regards to their medicines-related needs and pharmaceutical care. Now, this puts Johnny on the spot. This puts our pharmacy absolutely in the community pharmacy. This definition means that the public enjoy more access to a pharmacist in a community pharmacy and not less so, which would be the case had we pursued the plans being put forward by the department around remote supervision. So yes, we want the rules on supervision to be reformed. We want the pharmacist to be more available to the public and not less so. We actually believe that this can be done through skill mix, because at this moment in time, lots of people in healthcare, primary care in particular, are working hard, but they're not really working smart. They're doing all sorts of jobs when they should actually be concentrating on the areas that they have unique skills in, and allowing others who've got unique skills in those areas to get on and do those jobs. And that means mixing up these jobs and placing them with people who will have the skills to undertake those particular tasks. Now, this is the current situation diagrammatically as we see. Up the top there in the blue box, the patients are creating an ever-increasing burden on primary and secondary care. Loads of demand being placed over there. The government's view, and we have to agree with this, we have to understand where they say is, at this moment in time, largely speaking, patients are coming to pharmacies for a transactional experience. They're bringing in their prescriptions and they're purchasing medicines. The pharmacist is taking that prescription and inevitably is ending up in dispensary-based activities, in the dispensing, in the checking. The government do not attach a huge amount of value to that, because their problem is upstairs, somewhere between the patients and the burden on primary and secondary care. They want pharmacists to take more part in that grey part of that box over there. So their idea is this. Patients go to a pharmacy to handle their prescriptions and medicine sales because the pharmacist in that grey box down the bottom there is no longer in the pharmacy and undertaking roles somewhere out in the wider environment. This is the plan that we can't support. Our idea is somewhat different to that. Wouldn't it be good if patients could come to the community pharmacy to be faced by a patient-facing pharmacist, just in the way that the community pharmacy contractual framework is requiring them to, more patient-facing activity and clinical roles. The pharmacist could be involved in those. These are new tasks and activities, including not just the clinical check on prescriptions, but actually the wellness and health check of those patients as they walk through the door. This is a patient-facing role. The only way they can do that is once they've undertaken those important checks, they hand the prescription on to the pharmacy technicians to undertake the physical task of assembling the medicines before handing them out to the patients. This is how we mix the skills. The pharmacists are involved in the professional activities. We give the technical assembly issues to pharmacy technicians and enable them to manage the entire dispensing process. But there's a problem. We recognise this. We've done focus groups to death. We've written a big report on pharmacy technicians that's 271 pages long. I wouldn't recommend anybody read it unless you've seriously got long-term insomnia. But the real issue here, pharmacists not wanting to delegate to pharmacy technicians, is that 3/4 of pharmacy technicians today are there by dint of grandparenting. When we said to the GPHC, why don't you create a ruling that says if a pharmacist passes a prescription to the back in the dispensary to a pharmacy technician and something goes wrong, you'll hold that technician responsible professionally, the GPHC have told us what the GPHC has done is to create a register for pharmacy technicians. However, a large proportion has joined the register through grandparenting, and as a result there are some very variable standards amongst those on the register. Very variable standards, that's an important phrase. It is therefore not possible for the GPHC to take a blanket view and to recommend to pharmacists what roles they should delegate to pharmacy technicians. A generic approach to the entire group is not possible. And we say, at this particular point in time. So, what is the reluctance amongst pharmacists to delegate? We've done lots of focus groups on this. Well, clearly there are concerns over the condition of the pharmacy tech register, the extent to which grandparenting is relied upon. The definition of the current pharmacy technician role is far too vague to be relied upon, because you can be a pharmacy tech, registered with the GPHC and do some activities. You can be a dispenser and do the same activities. You can be an accuracy checking technician, unregistered. You can do the same activities. There is no real regulatory traction or protection. This whole issue is too vague. Pharmacists clearly have got concerns over the regulatory, civil and criminal liabilities. Their head is on the block. Their certificate is on the wall. That's the position and has been historically. This is something we need to fix. And frankly, those long-term concerns over the government intentions, as announced by Lord Warner in 2006, have created a huge amount of resentment and suspicion, and frankly have put the brakes on any discussions around supervision. And this needs to be seriously addressed and quickly. So how do we make progress? I don't know how many of you know this, but there's lessons that we can learn from the dental sector. When you go to the dentist and you're lying there in the chair, or your child is, and the dentist is leaning over to you, there's often a happy smiling person sitting in a chair over there, usually wearing a blue uniform. I didn't know this until we started to research this. Transpires this person has got a huge amount of regulatory requirement placed upon them. Their training specifically focuses on several areas. One of those areas is that they have to be able to accurately record whatever it is that the dentist is saying. So when they're looking in your mouth going left 6 molar, right 6 whatever, hole, needs filling, they are accurately transposing that into the computer system. The next thing is they have to be able to hand things to the patient whenever the dentist calls for them. So if the dentist suddenly and urgently needs some equipment, that nurse needs to know what the equipment is so they can hand it to them promptly. They're responsible for sterilising all of that equipment, and ultimately they're also responsible for that blue liquid with the tablet in the glass by the side of the couch. They're responsible for first aid in the event that there is a terrible bleed, and in particular in the area of resuscitation if somebody should have some kind of an attack in the chair. And frankly, they're also there inherently for chaperoning purposes, ensuring that there's never a situation where a dentist is on a simple one-to-one with a patient. Now, those are things that have actually been cemented into a specific training course that enables that dental nurse to take that qualification and that title, and it is a protected role. And what it does, if you imagine you were a locum dentist, is you know it's absolutely rock solid that the dental nurse in the corner is going to enable you to do the job. Now imagine if we had that situation. It's called credentialing. Credentialing regulated by the GPHC. It becomes a regulated role. Suddenly you're able to gravitate over the quandary and the problem that we have over the pharmacy tech's vague qualification and create a regulated, protected title higher up the tree that might be called a community pharmacy dispensing and accuracy checking technician. And you know that if somebody's taken that test It doesn't matter whether they've come through grandparenting or where they've come from. Now you've got an absolute, transparent, rock-solid qualification that you, as a pharmacist manager, as an employee, as a locum, can rely on. And the important thing is this person needs to take with them some regulatory traction through taking regulatory responsibility for getting things right or wrong. And it means that you can confidently then delegate to this technician, knowing that if you've done your job right and there's a picking error or a sticking error, this regulated person will take the regulatory responsibility for that. You could develop this further. You could create a hospital pharmacy ward-based technician, a primary care pharmacy technician, a GP practice-based one, all of them having specific qualifications and specific requirements. So, how would it work? The clinical check and much more patient-facing activity. We need to determine what constitutes a clinical check. The delegation of dispensing process to the dispenser accuracy checking and pharmacy technician. And finally, the pharmacy technician sits below that, but that becomes an entry qualification for pharmacy technicians who are then able to take the exam to give them the next level up, which is the one that we seek to rely on. Clearly, within each of those categories, you could then set up a structured career framework allowing basic, advanced and specialised pharmacy technicians. It wouldn't be too difficult to see how some of these more advanced pharmacy technicians could start to work in that grey area between technical and professional, helping people with their asthma inhalers, perhaps helping people with their vaccinations going forward. I promise you that we've got to crack establishing the new regulatory and civil and criminal accountabilities. We truly are expending an awful amount of energy on this and we're making progress, but that's not for today. So that's it from me. Those are the PDA's ideas on how we might create a new supervision regime. We are extensively going around the UK engaging pharmacists in focus groups. Thank you for indulging me for the last 20 minutes or so. I wish you a fantastic conference. So sorry I can't be here, but have a wonderful time and thank you for listening.